Donna, Happy New Year, my friend. It
Happy
has
New
been
Year.
way too long.
Yeah, and happy new season, right? Season 4.
And
Here we
happy
go.
new season. Yeah, this is the second year of the Med List. Thank you all for joining us here. I think the goal, I guess, with my name, just putting Kevin there, is so I can remember to lose weight in general. I can really slim myself down. Any New Year's resolutions for
Is
you,
that
Donna?
your New Year's resolution?
Right.
I actually am trying to read more. So other stuff, not just all the medical things.
All
Just
the
trying to read a
nerdy
little bit
stuff.
more. Yeah, just
What do you read, Donna? Like what
um,
tickles
I
your
just
fancy?
finished The Tattooist of Auschwitz. Can never say that right.
Yeah.
Which was excellent. So
Okay.
yeah, so just kind of trying to read beyond medical. So yeah.
Read beyond medical. I love that. I was talking the other day to someone and said I didn't realize that having two small boys would be such a positive piece of sticking to my resolutions. So, for example, I wanted to drink more water and take a multivitamin every morning, and so that was my small bit. But I told both my boys that's what we do in the morning. Like we drink water together and we take our multivitamin without fail. I've got two alarm clocks to tell me like, hey, Dad, it's time to drink that water and take that multivitamin. So when it comes to adherence to regimens, those little ones, they can really be quite influential. In fact, somebody I was talking to said, a coworker of mine said that her father had his granddaughter getting on him about smoking. And he went and he smoked one day and he said, oh no, she's going to be so mad at me. So there's real fear, from
Yeah.
granddad thinking about their kids getting after him. So I think that's too much fun. But at least for us, I think this year, Donna, the real objectives overall is just trying to simplify the show for our audience. We're trying to do two segments. So I want to introduce you guys to one piece is called About Them. So that's going to be about our guests. So when you guys view, you can see that first section that's going to be about them. The second section is about you. So really our guests then talking to you and telling you, here are the things you should take away, from the lessons they've learned throughout their career and the things that they're working on today. And I think without further ado, Donna, should we get started on this first episode?
Absolutely.
Yeah.
Absolutely.
Okay.
So we have a couple of wonderful guests with us, and I love what our topic is today too, Kevin, where we're talking about hypertension, because I think that's probably a goal for many people, is to really get that into compliance, if you will, but how much is too much too. So today we have with us Dr. Cheryl Sadowski. She's a professor at the Faculty of Pharmacy and Pharmaceutical Sciences, University of Alberta. She has research interest in geriatric syndromes and deprescribing. She's one of the authors of a recently published Decolonizing and Indigitizing Medication Appropriateness in Canada. And she's done that with the Canadian Medication Appropriateness and Deprescribing Network. So welcome, Cheryl. Thank you for joining us today. And we also have with us today Dr. Roni Kraut. She is an assistant professor in the Department of Family Medicine in the Faculty of Medicine and Dentistry. She practices in primary care, clinical, and long-term care facility in Edmonton. And her research is based on questions that are related and impactful to primary care, with a focus on deprescribing, preventing overdiagnosis, and population screening. So I just love this combination, and welcome for joining us too, Roni. Thanks for being here today. And I have to say, I am intrigued about a few things today. One, we all have the same thought of deprescribing. I love that we're talking about hypertension because it's such an overwhelming issue for so many people. But I also think it's so important that we're talking about when the treatment is too much too, when we go too low with that blood pressure. So just wanted to share just a couple of little statistics that I kind of researched a little bit on. You can tell me if I'm close, but at least in the United States, I know you guys are from Canada, but half of the adults have hypertension. So just under 120 million people in the United States have hypertension. 25%, only 25% have their blood pressure under control that have hypertension. So that's only 27 million of that 120 million. But what I found was super interesting is those that are on hypertensive medications too, especially our older adults, 27% of those, and the older adults, actually are too low with their blood pressures. They go way low. And I think we're going to be talking a little bit more about that too. So just kind of wanted to set that up a little bit for what people might be thinking and hearing from all of you in regards to blood pressure and too much treatment too, and maybe not enough either. So welcome both of you, Cheryl and Roni, and thank you for joining us today.
Thank you for hosting us.
Yeah, absolutely. So would love for you to tell us more about yourselves and, how you got to the interest in what you're doing, pharmacist and doctor, and thinking about the deprescribing and hypertensive studies.
Well, I can comment. As a pharmacist, I am in practice. I work in a geriatric outpatient clinic, and so I see some undertreatment, but mostly a lot of overtreatment and polypharmacy and fairly aggressive attempts to titrate people to guidelines. So in Canada, our hypertension guidelines are updated every single year. They have a really strong presence. People are familiar with them. They're well branded. And so people will look that up frequently. And so they're always thinking about what are the goals? What are the targets? Which algorithm should I use? How quickly should I start patients? What about their comorbidities? And so that's always front of mind. But there's not very much thought about, am I overtreating? Is this overall good for the patient? So I see that in my clinic that I work in, the interprofessional clinic I'm in every week. And then as an academic, I'm also involved in teaching mostly pharmacy students, but some other health professionals. And, the students come into the class and they're gung-ho on guidelines. They're really, as if that's the final word on all clinical decisions. And they know the guidelines, they know the targets, they know the numbers, they know the algorithm, and they always want to be starting things and being more and more aggressive without thinking about the risk. So in my teaching discussions, in my clinical discussions, this is coming up. And over the years, I've had the opportunity to work with the Canadian Deprescribing Network. So that has a slightly updated name now, Medication Appropriateness and Deprescribing Network, but we call it CADEN. And I interacted with some of my pharmacist colleagues in geriatrics, some physicians who ended up starting CADEN. It's 10 years ago now. That started in 2015. And I had the opportunity to do a sabbatical at CADEN and serve on a few of the committees. And so hearing about what's happening nationally and internationally has been something that's really kept me engaged with overtreatment and overprescribing. And so kind of all of those clinical, teaching, research areas kind of intersect where I think this is a really important area that we need more pharmacists looking at and advocating for. So over my years in pharmacy, I've really was focused more on reducing treatment burden and harm in the last 10 years of my work.
Yeah. I love that, reducing treatment harm. That's in burden. So important. Thank you. That's amazing. I love that you did a sabbatical with CADEN. That's really neat. What a nice mix to be able to do that.
Yeah, it's a separate podcast altogether, but I recommend anyone in an academic setting to consider strategically what to do for a sabbatical. And these types of partnerships have been very good. CADEN is a leader internationally and also quite well connected with the other deprescribing networks. And so as an academic, it's also, really enhanced my networking and contrasted what's happening elsewhere. So it really expands your horizons and gets you to appreciate there's a lot of other creative ways that they've tried to solve some of these problems in other countries, other jurisdictions. And if you can take the time and do a sabbatical, you can learn a lot by going to another place and learning from other experts. So
absolutely. And Cheryl, not to forget too that that's how we met, is through the International Conference on Deprescribing, and here we are doing podcasts together. So the networking works. We learn from each other and get excited about what the other one's doing. So yes, absolutely, I can't agree with you more that these collaborations are so important. So thank you for that. And Roni, what about you? Can you tell us about your world of your practice and hypertension and deprescribing and studies that you've done?
For sure. So I work as a long-term care, partially as a long-term care physician, and also I have my own family practice. So in long-term care, when someone's admitted, typically they're on at least, I would say, 2 or 3 pages of medications. And I normally sit down. It takes me at least 3-ish, 4-ish hours to go through the medications, looking for why are they on it, going through old records, talking with them, talking with their family, with their caregivers, and typically get that list down to hopefully around 4, 5, or even less medication. And often on that list is antihypertensives. So I've become very familiar with deprescribing antihypertensives and looking at how do you do it most effectively in long-term care.
Yeah, that's amazing. Yeah, and that's so true, right? That's what we learn talking about the guidelines and algorithms for treatment. It is the multi-pronged doses of so many different medications that are being used in order to treat blood pressure. But then again, for how long, right? You're on this for life kind of thing is not really true any longer, or really should never have been true originally.
Is that what ended up having you guys meet? Is it your interest in particularly hypertension? Is it deprescribing? What's kind of the backstory on how the dynamic duo was formed?
Well, maybe I'll start on this one. The backstory is this is the protocol for our antihypertensive randomized controlled trial called Optimize BP. Started when I was a master's student, so this was my master's thesis.
Oh, amazing.
And at that time, I was working with the Institute of Continuing Care and Research in Alberta, and they were helping me with it. And I had talked to the executive director, Sandra, about being able to connect with a pharmacist that has an interest in deprescribing, because I wanted to talk to them about the protocol and what they thought of it. So they connected me with Cheryl. And Cheryl spent the time to go through my entire protocol, provided excellent advice, and suggested how to do the algorithm also. And that template for the algorithm is what we actually use. And since then, we've been collaborating.
Oh, that's awesome.
Wow.
So
How's it going?
The collaboration is going fantastic. You calling us a dynamic duo, that's very inspiring. We are just, I guess, 2 hardworking academics trying to solve a problem that we see every day in our practice. So it does come down, I guess, a little bit to networking, as Donna was saying, that there's lots of different groups working in geriatrics. So some advocating for this, some focusing on falls, some specializing on incontinence, some advocating for access in long-term care. There's a lot of different little subgroups, but it was nice to have an organization that was really focused on advocating and also dealing with therapeutics issues in long-term care. So we're really appreciative. Sandra has since retired, but we're appreciative of the work she did, the advocacy and the facilitation she did in bringing people together. And so it was, even though running the same university, we're in different faculties. We wouldn't necessarily have crossed paths. And so that was kind of nice to be brought together and realize that we really had a lot in common, and we really wanted to see some of these issues addressed. So we've had a number of years now of just sharing ideas and brainstorming and working with each other's students and trainees. And it's helped me, but I think it's also, I hope we're modeling for the next generation. You can have these really rich interprofessional collaborations, getting other trainees to think about how they might work. If they're a physician, how would I interact with the pharmacist to help solve some of these problems? And then they also give us ideas for, our research activities as well. So it's been a very inspiring opportunity to work with Roni.
So how did you come about with, I know that Roni, you had mentioned that you were doing this as a thesis. And then, so what sparked your interest here in, during your master's program, and then getting Cheryl involved too? And then how did you build this further, and how did your study come about? And can you just tell us some of your findings too, during that study time, and maybe some aha moments?
Sure. So really my interest in this topic was really by happenstance. I had heard about deep prescribing, and I had worked with a geriatrician on one of my rotations that was very into deep prescribing, but I wasn't like that. I wasn't thinking of it potentially even as a research focus. My master supervisor, Scott Garrison, was just looking at doing a study on antihypertensives in long-term care, but not on deep prescribing, looking at the time of day the medications are taking, morning versus night. Does that impact cardiovascular events? And when I started looking into the topic, what really piqued my interest was not the time of day, but rather should the frail older adults in long-term care even be on antihypertensives? And looking at observational studies, they typically point to antihypertensives in frail older adults not improving cardiovascular outcomes or even worsening cardiovascular outcomes. And observational studies also point to adverse effects from antihypertensives in frail older adults, but there hadn't been a randomized control trial on the topic yet. So I thought, perfect, that's something that I could look into. And so that's sort of how I got started on this topic. And since I've started on the topic, and Optimized BP has come from my master's thesis to a pilot, to being a full study, to recruiting 22 long-term care facilities. Almost all long-term care operators in Alberta are participating. I've started to become a lot more interested in deep prescribing. I have done more in deep prescribing. And now this is definitely one of my research topics.
Interesting. So you mentioned before too that you also have this primary care clinic as well. And I'm assuming you're seeing older adults at that clinic too. So is your approach extremely different when you're looking at older adults that are in long-term care versus older adults that are ambulatory? And how might that differ with your approach for either treatment or deprescribing?
Yeah, no, that's a very good question. And my approach is completely different in long-term care versus in my regular practice. Because evidence right now is pretty conclusive that blood pressures over 140-ish systolic will lead to worsened cardiovascular outcomes in the regular adult population. So when I see an adult in my family practice, and typically they have a blood pressure consistently over 140, our discussion is we should probably start antihypertensives or work on lifestyle interventions and monitor. Whereas in long-term care, it's very different, because the reward or the benefit risk balance is very different in long-term care, frail older adults that are on antihypertensives. For frail older adults, now you have more risks of adverse events like falls, like cognitive issues. And at the same time, there's no clear evidence of benefit. And often the residents I see in long-term care, their blood pressures are never really elevated. Often they're low or normal or lower end of normal. So it's a very, very different conversation between like regular family practice and long-term care.
So interesting. Yeah. You did mention something, Roni, and Cheryl, feel free to jump in there too. When you worked at these facilities, these 22 facilities that have signed on for this individual study, one thing that's difficult, I think, from an academic standpoint is always taking something that's theoretical and then applying it, right? What have been the positives and the negatives thus far of applying the protocol out into a larger, wider setting?
Like in general, it's worked very well, because one thing that we've done with the protocol, and Scott, so my mentor, also on this, has always said you want to keep it simple. You don't want to complicate it. You want to make sure it's doable. So it was always, let's go for the easiest, simplest option, because if it gets too difficult for these long-term care facilities, they're not going to be able to do it. It's going to be difficult for them. So that's been very important in the protocol, is keeping it very manageable. And the algorithm we have is very straightforward. I mean, we can typically, we just, to explain it to pharmacists before they start, we do an hour session, and that's all we give them. And we give them the algorithm, and they're able to go out and do it. So that's the big thing, is just going from the actual study to the implementation, is keeping it very, very simple, very straightforward, very doable.
Yeah, I don't think you guys could have simplified it a whole lot more on the way you've broken that down. And I know we're kind of transitioning from the about them to about you now section, but Donna, when looking at this, it's refreshing, right? Of just how simple it's become here. And is there no indication, right? You know why you're on an antihypertensive. If there's no known indication, then you recommend deprescribing. If it's just for hypertension, then you recommend deprescribing. And then you go on to some other pieces that I think, always add a little bit of conflict, especially today. We're talking about the use of lisinopril in diabetic patients, et cetera, of kidney protection and all these other effects of individual drugs. We've seen the exact same thing with SGLTs and GLP-1s now in diabetes patients, that there's additional impacts outside of the initial clinical focus, meaning we were just using them to lower blood pressure, but they do other things for us. And so we're keeping some of these drugs on, and it can be problematic for our older patients. So the fact that you guys have broken it down so simply into these categories, I really appreciate. And I'm sure that our viewers, both patients and clinicians, will appreciate the simplicity. At the same time, I'll bet they're saying, how could it be so simple? Like, how did we get here? Your guys' thoughts on that?
Well, I'll add, I think part of why it was well received is we were working with pharmacists who are in a province, in a jurisdiction where they actually have a very broad scope of practice, and they have what we call additional prescribing authorization. And so this jurisdiction has, the province of Alberta has the broadest scope of practice for pharmacists in the world. And so if they've graduated within the last 17, 18 years, this is what's been happening in practice. And so pharmacists have learned to adapt prescriptions, rate new prescriptions, be responsible for some of the lab work, ordering tests. And so pharmacists have more of a role in Alberta in making those decisions. They're still communicating them, but they can make them in a way independently. They don't have to be authorized by another health professional, and that's the case in other jurisdictions. So we have a setting that's sort of ripe for this kind of work, in that pharmacists are now quite familiar and comfortable with taking the responsibility for prescribing and deprescribing, and with a little bit of direction, a little bit of support, then it's up to them to make decisions as to where do I want to start? Which of the maybe multiple antihypertensives should I start with? What's going to be 1, 2, 3, et cetera. And so I just wanted to add that as well. The anytime you think about research, the conditions have to be right in the environment for people to pick that up. And there's most physicians are very comfortable with this as well. So the ones, it's a study. So the ones who were not supportive or decided not to be part of the study. There's some settings that logistically it just didn't work for them with their staffing, the context, what have you. So we have people that chose to participate, but I think it's reflective of how most long-term care is happening here in Alberta.
So just in general on the protocol, or what generally happens in long-term care, how often are people having their blood pressures checked? Is it a daily thing that happens? Is it once a week that it happens for long-term care? Is it when they're new and adjusting to the long-term care? Does it happen more often and then eventually gets tapered off? I just know that it varies here in what I've seen in long-term care, and I'm just curious what it's like for your practices.
Yeah, so the standard is when you're admitted to long-term care, probably like 1 blood pressure on admission, and then after that, the standard is monthly blood pressures. For optimized BP, for the deep prescribing, we ask for 2 blood pressures a week. Ideally, I would have loved more than 2 blood pressures a week, and I think often pharmacists would have also, but more than that would be very burdensome on the staff, and already potentially burdensome to do those 2 extra blood pressures a week on all the residents in the intervention arm. So we just went with 2 extra blood pressures while they were being deprescribed, and then after that, go back to their monthly blood pressure.
And so, so once they were stabilized, if you will, on a deprescribed protocol, how much of an increase did you really see with someone's blood pressure? Was there, how often might you have to restart something, maybe even? So did you find that there were some of those situations?
And this was a really interesting result of the study, and we're not going to have final results until the summer, fall. But when I got the pharmacist data back, when they provided spreadsheets on the deprescribing and the blood pressures, it seemed to be almost no relationship between deprescribing and blood pressure. Maybe it would go up, maybe it would go down, maybe it would stay the same. Very different from, the regular fit older adult, where of course you give blood pressure, you expect blood pressure to go down. With these patients, and there were over 200 of them, I really didn't notice any relationship. Often blood pressure stayed the same. Sometimes it went down, sometimes it went up. There really was no correlation as far as I can see.
Wild. I mean, that to me is interestingly wild, right? That you have a pool of 200 individuals and you're pulling those many meds off. And for our group here, for those listening, as you heard previously from Roni, you're talking about patients that have 4 pages worth of medications. So there's lots of things at play to make that what seems like a wild fact if we just isolate it with blood pressure medication going away by itself versus we've got a slew of chemistry happening on top of that that really complicates things in lots of ways. Can you guys talk to that a little bit for our audience of what ended up happening? You read, Roni, some of the literature that was there, and Cheryl, you've experienced in practice of patients having too low of blood pressure, right? Or those blood pressure medications being on board and causing problems. What were some of those things that you were seeing so that folks can kind of recognize if that's them?
I could comment on this, or Cheryl, do you want to? Maybe I'll start. So one thing often is orthostatic hypotension. So for instance, if you're going from lying to standing or lying to sitting, you may feel lightheaded. Lightheadedness when walking, potentially, and predisposing to falls is another one. And another thing to look at, which is difficult to identify, but there is evidence that being on an antihypertensive when you're a fairly older adult and you have low blood pressure could worsen cognitive decline also. So something else to keep in mind.
Cheryl, did you have additional things to add there? Looks like you're still on mute. Let's see. There you go. Now you're on.
Sorry, unmuted now. But I think I wanted to add that part of why pharmacologically you would predict when you stop an antihypertensive, the blood pressure should go up or the heart rate should be faster. But I think we understand very little about how medications work in frailty, and the predicted responses aren't always there. And so that's why sometimes when we start medications, they're not as effective, or sometimes they're far more toxic than we ever predicted. And so there's so many physiologic changes that have happened with aging and with frailty, with that decline that, and most of these patients or residents in these facilities have frailty. And so there's been very little, pharmacology research and toxicity research. And so I think as we look at this as a really frail older adults as a select group, I think it seems surprising when we get these results, but it's highlighting for us these their bodies have really changed quite a bit, and the medications are not going to be as predictable as when they were studied in a 21-year-old fit 70 kilogram volunteer. And so just thinking a little bit more broadly about when we think about equity, diversity, and inclusion, and some of that concept is addressing ageism as well, thinking about advocating for older adults, and especially frail older adults being the focus of more research. So we can not be surprised when we have algorithms like this, what's going to happen to these frail people.
Do you find that, or were you able to look at various blood pressure or types of blood pressure medication, and did that play a factor at all? Was there anything that, I hear what you're saying, that, we just don't even know, like this whole frailty side of things, but was there any correlation, or were you able to say like, this is really important if someone is on this certain type of blood pressure medication that we should really try to deprescribe here, where another one might not be as, as much of a change for a patient, if you will?
We had a lot of discussion about this as we planned the algorithm. We first proposed it, I guess I would say. Should we say beta blockers should come out first? Or, there's not that many people on centrally acting medications like the old drugs like reserpine or clonidine. But, so we're dealing mostly, we know just from the data that we're mostly dealing with ACE inhibitors, angiotensin receptor blockers, calcium channel blockers. So we kind of knew what the lay of the land was. And we decided there were so many comorbidities, or so many if this, then that, the algorithm would be too complex and people would disengage and not participate. And we felt it also, I wouldn't say undermined, but didn't support the pharmacists in their clinical decision-making to lead this. And so they would know maybe which medications could be associated with which kind of withdrawal effects, what other comorbidities are being treated, what would be the downstream effect. And so we felt that it kept the algorithm simple, and it's in a way a natural kind of study, in that we're observing what are the pharmacists doing, what is their behavior, is there a practice where they're all picking the beta blocker, or are they all picking the calcium channel blocker? And so we're going to analyze that at the end. What was the pharmacist's behavior, and what was some of their approach to that decision making?
That's fantastic. So there's a bunch of international guidelines, right, on what is hypertension, what stages are pre-hypertension, where should you treat to, et cetera. And looking at your guys' guide, which I do love the simplicity, and the way, Cheryl, you break that down of just saying, if you make it too nitpicky, everyone loses, right? It becomes just too much of a labor intensive kind of work for the patients, for the providers, the entire clinical team. But a couple things that I noted on your guys' algorithm here is, one, you only pulled out systolic blood pressure. Like, that was the only piece there. Diastolic is not mentioned. So for the folks listening, that's a top number, the higher number versus the lower number isn't mentioned there. And then you also chose that the taper is to 140 plus or minus 5. So what were the reasons, I guess, first you chose the 140 plus or minus 5 for kind of that target? And then two, what was the reason that you decided not to incorporate the diastolic component? Cheryl smiling. Oh, now Roni is too. Uh-oh.
Well, part of it is based on our Canadian guidelines. So we had to use numbers that were familiar to a Canadian audience. And so our Hypertension Canada guidelines have 140 as a target, an emphasis on systolic blood pressure. And so we used the guidelines people are most familiar with, the numbers they were targeting in most cases. Yes, there are different numbers in those guidelines if someone has diabetes and complications from diabetes, but that was kind of the standard number if someone is just being treated initially. And so that's where most older adults would have been targeted. And so we felt that was reasonable to build on the guidelines, encouraging treatment with their emphasis really on managing systolic, with diastolic not as much of a priority within the Hypertension Canada guidelines.
Interesting. I need to ask, just because, and it's all a part of that whole Canadian world, the Think Cascades, the number one issue on Think Cascades, Lisa McCarthy and gang, is amlodipine causing edema and then a diuretic being added on, right? So what happened when you started taking off all of this amlodipine? I'm assuming, because that seems to be a fan favorite for many to be on. Did you see a great change in edema for folks too when you started pulling off these hypertensives that might be increasing the risk of edema for folks? Was there a shift that way that you were able to notice, or were you able, to eventually stop the diuretic, these prescribing cascades, pretty easy? Was that all a part of it?
Yeah, so I know in my practice, definitely I notice that I'm amlodipine more likely to have edema. I stop it, the edema gets better. But in this study, we designed it partially because of low budget, partially because just to be more efficient. All of our data comes from routinely collected administrative data. So we don't actually look at edema because we don't have nurses in evaluating everyone in the study on specific criteria. We're just going to be getting our data from whatever data is already being reported. So we unfortunately won't have data looking at, does edema improve? Very likely it will be, but we won't have the data. Yeah. One thing that we do have data on, though, is somewhat similar, maybe not quite, but somewhat similar, is pressure ulcers. Wow. And looking at that, because that's a part that it makes sense. If you're on an antihypertensive, you potentially have less perfusion. So therefore, and that's a huge issue in long-term care, is all these ulcers that aren't healing. So by taking off the antihypertensive, do people have less severe ulcers? And we are able to get data on that part. So we'll see it. We'll see. Hopefully we'll be able to have enough data, and we'll be able to look at whether there is a difference.
That's incredible. So reduction in pressure ulcers is what you would see. So your folks, when you've actually started to reduce them, you would see it was probably part of the assessment, if you will. Are there pressure ulcers present?
Or a lower grade of pressure ulcer. We actually have the data on the different grades, so we could look at whether people have a lower grade versus higher grade.
Wow, that's great. That's wonderful. So what are your suggestions after all of this, right? What are your suggestions when you're taking a look at this data and thinking about empowering others, especially prescribers, I'm thinking right now? How, we know that there is this quote unquote lack of evidence that make people, prescribers, maybe hesitant about deprescribing something. And what do you have to say about that now that this study has come out? What would you share with your colleagues in helping them ease this difficulty, if you will, with trying to practice deprescribing, especially with antihypertensives?
I can start, and then Roni can add a bit more from a physician perspective as well. But I think for me, it's been really a positive thing to see how safe and feasible this is. It's nice that we have not only this study, but there's others internationally looking at hypertension management in older adults, frail older adults, and cutting back. And so as part of our work, we've connected with people in France, in England, in the US, where there's other studies going on. So in another year or two, we should have a number of studies that you can look at to see that in frail older adults, there is going to be evidence. It will tell us maybe there will be direction on how low their blood pressure should be. So maybe how many medications should be discontinued, what their blood pressure can go up to, what's tolerable, how much safety improves, if there's less falls, if there's less complaints of dizziness and orthostasis, better improved healing, such as pressure ulcers, less edema and cascade. So this evidence is accumulating now. So I think it's encouraged me that there's not a signal right now that there's more harm. In fact, we might see another effect that there is reduced harm, that we're monitoring patients more carefully and stopping medications that are leading them to fall or have healing issues. So it's quite feasible. It takes a little bit more monitoring. You have to check the blood pressure a bit more. You're watching that patient a bit more carefully, but it fits into kind of the routine for when you're reviewing medications anyway. And as Roni said, we've set up the study where this is data that's being collected. So you don't have to come up with, an extraordinary intervention and hire a whole bunch more people. This can be integrated into your practice. And it looks like our initial signs are this is a safe approach.
That's great.
Tell me this one piece. Just so the folks know at home, in most studies, there's inclusion criteria that are included, and that's included in Cheryl and Roni's study here. And your guys' inclusion criteria is greater than or equal to 70. And it looks like our long-term care facility resident for at least 30 days prior to randomization. So a couple of those factors I think are really fascinating. Then obviously the hypertensive medication and 2 health system encounters with the diagnosis of hypertension since 2002. Okay, so all those factors kind of being included on who you're including in the study and pulling back from. What kind of screams in the back of my mind is the American Heart Association saying, oh no, everybody's going to get a stroke or a heart attack, right away. Those are the 2 things. You're going to pull them off the antihypertensives, and those things are going to knock through. Here's the guidelines to be able to show you. Here's the data, et cetera. But you guys have chosen particular patients, right, for a particular reason. What's the reason why folks listening at home, both clinicians and patients, should be cognizant of who you chose and why you chose them for this de-escalation of therapy?
So I think our criteria was pretty inclusive of most people in long-term care. We specifically chose 70 or older, thinking that anyone younger, maybe there is more of a benefit to the younger age group. So let's go with 70 and older. The one major exclusion criteria we had is congestive heart failure. If someone had congestive heart failure, they were excluded. And the reason is because it seems like there is evidence that antihypertensives and congestive heart failure are helpful. So we didn't want to include those people, but everyone else, diabetics, I can't think of other subgroups right now, but we pretty much included everyone besides that congestive heart failure group.
That's great. And that's a big population, right? It just even thinking about being that inclusive with the study, that's really important because hypertension is so prevalent and continues on. It's one of those diagnoses, right? So Roni, you, in your introduction, you work with being overdiagnosed as well, right? With those that are overdiagnosed. So, so are you taking away this hypertension diagnosis when you get people off of the hypertensive category at all?
Yeah, yes. So when I do take people in my practice, when I do take people off antihypertensives, they are no longer hypertensive. Although previously they probably were, which is why they were put on it. But currently, based on their current status, yes, they're no longer antihypertensive.
That's great.
It's one thing that I thought was really interesting. Roni mentioned earlier, Donna, I'm sure you caught it too, but with only 1 monitoring episode per month, right? And me thinking about our family members that we've discussed in long-term care settings, when we're looking at home, right, there's a lot of study and articles on how do you take blood pressure right at home? How do you diagnose hypertension in the at-home setting? And the number will surprise most people, right? So one thing is most of the time you have at least 2 daily readings. And at those 2 daily readings, you have 2 readings. So in other words, in the morning, you take a reading and you wait 1 to 2 minutes and you take another reading. And in the evening, you take a reading and then you take another reading. And you do that for a consecutive period of days, typically somewhere around 5 to 7 days to establish hypertension. Reason being is because your body will fluctuate throughout the day hormonally and have your blood pressures naturally go up and down, throughout the day. And 2, when you go and sit down and take your blood pressure, like I'm sure many of you listening have done, you're nervous. You go and see someone like Roni and think, man, what an intellectual giant. And you're sitting there in front of her and you're worried, right, about what's the number going to be? What is she going to prescribe me? And so that's another reason why sitting down, calming down, allowing your nervous system to kind of regulate itself is another big positive, because we hear a lot of terms out there like white coat syndrome, right? And that's when you see an individual in a white coat, you get nervous and your blood pressure goes up with it. So I have to ask you guys on the 1 blood pressure or the 2 blood pressures that you have there, any follow-up pieces or any kind of anecdotes from the outpatient world you'd like to throw in there? Because that is one that always does bother me, is we so whimsically just decide to diagnose on a single blood pressure in a 1 clinic appointment so often. And I think it gets our patients into way more trouble than we like to admit, but I'd like to hear your guys' thoughts.
I'll comment from the perspective of the pharmacist who was, on the front line implementing this algorithm. And so there was a minimum that that we expect how the patient's being monitored, but they also have data on these patients. They're looking back at the patient chart and records, and they're looking at patterns. If someone, just the month before had, systolic of 180, or there was, recent events, they could be making a decision that I'm not going to approach that for that patient right now. And so it was a minimum that we're monitoring, but the patients had, keep in mind, they're in long-term care. They have a chart, they have records for a fairly long time. So, it wasn't just that was the minimum for enrollment in the study. But we agree with you that it's, that long-term care is, in a way, it's a home environment as well. This is where they live. And they're, to have someone come into your room and check your blood pressure is still unsettling. It still can feel like, it's a clinical kind of visit, in invading your home space. And so what was an interesting item that I learned as we have gone through the study is actually how many residents in long-term care refuse to have their blood pressure checked. So we had thought it would be pretty much like 100%, like in the clinic I work in, patients just get their vitals done when they come in. And there's been a number of individuals that have refused. So we have we have some, I guess we could say, missing data because they can do that. And so, that's another element that added a little bit of complexity. But anyway, I'll let Roni comment on the whole issue of diagnosis and multiple measurements and some of her practice.
Awesome.
Yeah, so in my family practice, very, very often I see people in clinic with elevated blood pressure. And of course, I don't treat. I just say, well, why don't you just check your blood pressure at home, right? Sometimes when they don't have a home blood pressure monitor or the readings just don't make sense, we do like 24-hour Holter, just to get a true sense of what the blood pressure is. And the determination of also like how many blood pressures to do, how to do the blood pressure for this study. Ideally, it would have been great to actually, do that, 2 or 3 blood pressures, do like a blood pressure daily or twice daily, but we wanted to design the study to be feasible also. And to do it in a feasible way, we just said, do the blood pressure in the way you normally do it. Doesn't matter, just do it in the way you normally do it. And if it may be overestimated, but that's not a bad thing, right? Because then we're more conservative. And we did have all sites do a brief survey on how they actually do blood pressures, just so we would have a baseline of how do they do blood pressure. And I think all sites then do it like just one blood pressure, don't really look at whether it's in a relaxed setting, etc. So we have that information also.
Super useful.
Incredible.
I know we're running up on time here, Donna, but we did have, am I looking at one of the right questions that we want to make sure we got across here on what are your suggestions for providers and for patients, caregivers regarding like antihypertensives in general and deprescribing of those? I know that the study is focusing on long-term care, but please feel welcome to expand however you'd like.
I think it's encouraging clinicians to not be complacent. Hypertension is something that once it's on your chart, it seems to never be taken off, even if you had, an episode of anxiety at the doctor's office one day. And so these individuals have this label and it hasn't been seriously reconsidered, and things just get carried on. And so this inertia we want to challenge, because it's not benign. It's quite harmful when you have medication overload, and these are not trivial medications. They're affecting perfusion to people's brains, to their skin, to the other organs, and there's harm associated with that. And when it can be hazardous, but also just the unpleasantness of feeling dizzy frequently, or just having to take so many of these medications and then your feet feel like they can't fit into your shoes. These are things that really reduce quality of life and are indicators of toxicity. And so being complacent about something like that isn't acceptable. Just because someone is older or frail doesn't mean they need to stay on these medications. So I'm encouraging clinicians to really consider removing the medications, removing the diagnosis if it's that label, if it's no longer applicable for those individuals.
And do I have time to jump in?
Oh, absolutely.
Okay. I would just say also to have a really good discussion with the caregiver or patient and explain to them that there may not be that as great evidence as you would like on this topic, but that shouldn't stop us with making a decision of either to deprescribe or continue prescribing.
For sure. And I'm just curious, I'm just thinking the long-term care side, there's a big push in the United States, and I think really worldwide, to have more in-home long-term care. And I know some countries are really excellent at keeping patients at home or in their home environment. Do you find that there's a push for that in Canada as well? And would you encourage those who are the caregivers for keeping people long-term care at home? How might they be able to communicate better with the providers to say, hey, is this all necessary? And, what do you need me to do in order to maybe reduce some of these meds too?
I think it starts with just putting it on the table that, you're willing to have the discussion. Maybe in some cases, you're willing to add more medications. In some cases, you're willing to discontinue medications. And so just being open to that idea. We're finding the public is still learning about deprescribing as well. So, and then being part of the plan, being part of monitoring, gathering information. So not just checking a blood pressure, but even the work of maybe checking the orthostatic blood pressure, monitoring for edema in some ways, monitoring how you feel in terms of dizziness or if there's complaints there. So thinking about being part of that plan so that the decision can really be informed, and then monitoring once a decision is made, again, checking to see that there's not any withdrawal effects. So it's a bit of a process, but it's not it's really quite feasible.
Sure. Absolutely. I want to say thank you so much for joining us today. And I think this is such an important topic that people really need to rethink the meds that they're taking, rethink the meds that their loved ones are taking. And like you both have stated, have the conversations and be open to this could be. We can always add back on if need be, right? So, but we might find that we don't need to, and we're reducing people's med list from pages to just a few. So that's fabulous. I love the deprescribing side of things that you are doing in your practices.
I'll double click on the love. And I also, I need to adopt the Canadian pronunciation of process. Like it's so much more positive than process. Like it's so much more boring in the American tone. So I'm going to try that out, Donna.
Yes, I agree.
But the one thing I'm really looking forward to is the results of the study, right? So when you guys go through and get all that information, let's have you guys back to be able to let us know what you found out, over time. We'll put a link to the protocol inside of the show notes, and you guys can all follow there. And please follow us on the med list. And thank you for joining us today with the incredible Roni and Cheryl, the dynamic duo from Canada, to be able to help us understand deprescribing and blood pressure. Everybody, we'll see you very soon and have a wonderful evening.